we will discuss this topic of anesthesia, analgesia for circumcision. Okay, so Tayyab, can you hear me?
Yes, sir.
Okay, so Tayyab, what will be the choices for anesthesia or analgesia? Like, okay, analgesia for circumcision. What will be the choices?
Okay, sir. First of all, we can use this caudal block,
Okay.
and another option is using LMA with sedation.
Okay.
Other options are we can give just NSAIDs, paracetamol postoperatively, as well as as a preemptive analgesia.
Okay, so the chunk in the question which I am asking at the moment. Remember one thing, that we always think that circumcision is always in babies. Okay, but it's not true. In exam, this may be a confusion to you people. So of course it will be in our part of world. Definitely, whenever circumcision comes, it you will never think that an adult will be coming for circumcision. But remember one thing, that circumcision, the patient may be adult. Okay, it not necessarily it is a baby. So this thing, remember the one thing. Then anesthesia, any mode of anesthesia you can give with endotracheal intubation or LMA, whatever. So actually I will be focusing more on the analgesia part, or if you want to do it so solely in only like you want to perform because in the babies sometimes they are only giving the local and they are doing it. Okay, so like what will be the different choices? This thing. Okay, so what will be the different one thing you told caudal block? So there is one penile block. Okay, pudendal nerve block. And I'm sorry,
Saddle.
saddle. Yes, very nice. What else? Anything else?
Sir, it can be classified either as general or regional.
Okay.
If we opt for a general, because it is a quick procedure, so LMA is a good option.
LMA will be better choice. Just tell me one thing.
Ji, sir.
This is not actually direct related to it, but how will you compare LMA versus endotracheal intubation in babies?
In babies, generally in our setup, we only opt for a local.
Okay, but if we are giving general anesthesia, so how would just actually this is question related to LMA and endotracheal tube. So remember one thing, that there is high incidence of laryngospasm, okay, in pediatric population, and sometimes it seems a very simple procedure, but when you are doing it in LMA without muscle relaxant, sometimes there are chances of laryngospasm with secretions, or if a light plane of anesthesia is because it's difficult for you to, because in your back of mind it is a short procedure. Okay, so sometimes you are trying to avoid giving like you, and I hope you understand that the simplest of the procedure can create biggest of the problems. So whenever, this is also a practical message, that whenever you are doing this procedure in LMA, short procedure, be aware, especially in pediatric population, there is high incidence of having laryngospasm. So if there is laryngospasm, will LMA work, or what will happen?
No, of course not. Of course not. The patient would die.
Yes. So
the reactive airways will also contribute. So definitely, it's not a good option.
This is, remember one thing. No, it doesn't mean that it is a bad option. Always endotracheal intubation also has the problems, but the thing is that you should be aware of what you are doing. So that's my
Hmm.
message. Okay.
Ji. I understand, sir.
Okay. So I will just show you something because just a second. Where is it? Okay. So how many of you do caudal anesthesia? Caudal block?
Sir, me, I do.
Okay. So yes. So how do you calculate the dose for caudal?
1 ml per kg.
No,
Dr.
sir,
Humaira,
there is a formula for it. It's there's a special name for it.
Armitage.
I can't.
Armitage regime.
Armitage code, exactly. So it's actually a 0.5 ml per kg for the a specific dose for the lower region, and if you want an upper region, there's another dose, and upper thoracic again there would be another dose. I don't exactly remember the dose.
You can see the screen. So you will be seeing that if it is up to lumbosacral, it will be 0.5 ml per kg of 0.25%. Okay. And if you want low thoracic, you 1 ml per kg, and for higher thoracic, nobody actually use it. And now because it's sort of calculation, but you should be knowing that how will you calculate? Like if you have a 5 kg baby, so how much dose you can give for bupivacaine? According to Morgan Sharif, it will be 3 milligram per kg. But according to the standard text, it's standard practice, it is 2 milligram per kg. So it will be 10 milligram. Okay. So if you are giving 10 milligram, so maximum you can go up to because I'm just bypassing it, 10 by 2.5 will be 4. So you can go up to 4 ml of 0.25%. Okay. So for example, if you calculate it and the volume is coming more than that, for example, if you even make it 1 ml per kg, so it will be for 5 kg, it should be 5 ml. But here you are calculating that you cannot go more than 4. So what will you do? Yes.
So, sir, we will increase concentration.
We will decrease concentration.
Okay, sir.
We will, because we cannot cross 10 milligram. Okay. So we can, if we want to make 5 ml, we can make it 0.2% rather than 0.25%. So we will just dilute it. Okay. So this is one thing. And another thing is that we are not doing it for holy solely anesthesia usually. Okay. So we don't need actually higher concentration. Even if it is 0.1 up to 0.1%, it can work theoretically. Analgesia will still be there. Volume is important. You cannot decrease the volume. If you will decrease the volume, it will not reach it. Okay, so that's a message. That how you calculate it. Always calculate by percentage. We discussed in our last class, awake fiber optic. We calculate all these percentages. So it will be multiply by 10. Whatever percentage is there, so it will be 2.5 milligram per ml. Okay, and then you will accordingly calculate. So you never have to cross the dose. One more question. If you just compare with different blocks like upper limb blocks, lower limb blocks, and trunk blocks, okay, and like a central neuraxial block and intercostal nerve block. So where will you rate caudal block according to the absorption? Because least absorption is here among the nerve blocks, and where will you rate like after IV or IM?
Sir, after intercostal block, caudal block has the highest absorption rate.
So remember this thing. Okay, this is very important thing, that caudal block the absorption can occur very quick as compared to other sites. So this is important. I have never actually discussed with or read about it. Why don't we add here epinephrine? I don't know about it, by the way. If anyone has the answer, you can share, because I have never seen anyone adding epinephrine. Do you know the reason?
Yes, sir. Sir, bupivacaine epinephrine is not added, maybe due to its acidic effect like this. I have read somewhere.
No, this is not the reason, Tayyab, because all the local anesthetic preparations which we use are acidic. Did you lidocaine, hydrochloride, bupicaine, hydrochloride? You know the reason, Dr. Bano, do you know the reason why we make it acidic?
So there will be increased rate of absorption.
No, acidic environment will be decrease.
Ionization will increase then.
So it is not a bad thing. It is not a good thing. Actually, it is to increase the shelf life. Okay. So acidic is more stable, while basic is unstable. So that is the reason. So Tayyab, the reason for it, I actually, if you the problem is that why you add epinephrine. We need epinephrine add it for two purposes. One is to decrease the absorption, so there will be decreased chances of toxicity. Okay, and other is to increase the duration. Okay, so actually bupicaine is already having prolonged duration of action because of what factor of bupicaine determine its prolonged duration of action?
Protein binding, 95%.
Protein binding. It is highly protein bound. Okay, so this is the reason. So my thinking was that we can add epinephrine to decrease the toxicity, but I will search about it, that why we don't use epinephrine because it can reduce the toxicity. Okay, so you can also think about it if you can find the answer for it. So actually the thing which Dr. Banu, you were telling was pKa. So pKa should be nearer to physiological pH of 7.4. So it will be 50%, 50%. That is pKa. Okay. So if why lidocaine acts quicker, because its pKa is around 7.8, or in some books you will find 7.7, and for bupicaine it is 8.1. So at physiological pH there is more ionized portion of bupicaine. So its effect, like you can just to make it simple and remember, you will not forget that if someone is angry man and it's fighting with everyone, the guard will stop. So the ionized portion, you can say active, and ionized portion is angry. So an angry guard will say stop here. And the unionized portion is very smart. It will pass through the cell membrane, and inside it will become ionized. Do you know this? That local anesthetic effects from inside within the cell, and they become ionized to act. But ionized portion cannot cross the cell membrane. So that is the theory about it. Okay. So actually I have repeated this thing multiple times. This is for the people who have just recently joined our discussion. Okay, so I will just come back. So we discussed that we can give GA, we can give this caudal block, and Dr. Nadeem wisely told that if you are doing it in adult, we can also do it in saddle block. Okay, because we just need the sacral segments mainly. Okay, but yes, Tayyab.
Okay, sir, you continue. My question is, in our setup, our seniors give bupivacaine with lignocaine.
ਨਹੀਂ ਸੈਟ ਦਾ ਮਸਲਾ ਹੈ ਕਿ ਉਹਦਾ ਹੈਂਡ ਫ੍ਰੀ ਦਾ ਮਸਲਾ ਸੀ ਅੱਜ ਕਾਲੀ ਹੈਂਡ ਫ੍ਰੀ ਸਹੀ ਨਹੀਂ ਸੀ ਚੱਲਣ
Okay,
for caudal block, sir. In in Morgan, it is written when two local anesthetics are used, then total dose will be less.
Yes.
And
Yes, you know, I will highly suggest you because regional is my interest. Okay, and actually, I love regional anesthesia. I have discussed this topic a number of times, but I will repeat it for you because whenever we are giving two local anesthetics, okay, we have to add the doses, so it will be additive effect. So, for example, I will give you to make it simple. If you are giving instead of you want to give bupivacaine plus lidocaine, so you will make it half. So you will take 1 milligram per kg of bupivacaine, plus you will take, for example, if to just make it simplify, you will take 2 milligram per kg of lidocaine instead of 4 milligram. Okay. So it will be 0.5 plus 0.5. So 1 factor of dose will come. So this is additive effect. And why you want to make lidocaine with bupivacaine? To increase the onset. It will to make it fast. Okay. So if you and this is true for any block. If you want to make it quicker, you will add lidocaine. You can add bicarb. So bicarb, what will happen? That bicarb will make it basic. So more unionized portion. So more unionized portion, more quick effect. Okay. So this is the theory. And then you can add this epinephrine to decrease the systemic absorption and to slightly prolong the effect. But will you use epinephrine in this penile block?
No.
Why?
End
No,
organ
sir, not at all.
Vasoconstriction,
and artery.
damage,
Arteries. Because
necrosis.
it is end arteries, so you will never use it. Where else you will not use epinephrine?
Sir, the tip of the nose,
Digits.
the
Digits.
Digits.
Digits. Okay.
any end arteriolar, this could be even the retina.
Yes. Yes. You will not use them. Okay. So this is
Sir,
the.
I have a question. I have a
Yes.
question. I have actually two questions because recently I have done क्या कहते हैं, these circumcisions. Why would an adult want to have a circumcision?
Definitely, there are because actually because of some infections.
Phimosis, paraphimosis.
There are, I don't remember the name of the infection, because why actually the if we just pull out the religious factor, what is the medical indication for circumcision? That the skin, underlying skin, there are chances of getting infected. So this is the reason. Okay.
And also, sir, is a caudal block and epidural block analogous?
Yes. Where are we injecting in caudal space? We will just try to have a look at the caudal block. Actually, this document which I had opened is about caudal anatomy. Okay. So they can ask you where is the exactly the caudal block. Okay. So this actually this will be continuing with the epidural. This is caudal epidural. It's an epidural. Okay. It's the epidural space.
And sir, up until what age can you do a caudal block?
This is a very good question. I was about to tell it. Actually, I have done I met one of the anesthetists in Pakistan who used to do it in adults as well. And actually, the problem is that there are so many things to share. This caudal block can be done with ultrasound. Okay. So if you are doing it with ultrasound, it is easier for you to identify and to be sure. The problem is that sometimes if the area is very fatty, so in pediatric you may be able to find the landmarks. So this is one thing. So it is subjective. If you find the landmarks in adults, you can do theoretically, you can do it. Okay, so there is no age limit for that thing. And usually they are, but because the spread, because as the age grows, there is more and more fibrosis. So spread is not predictable. So that is the problem. It's not that we cannot do it, but there is no guarantee that effect will come. So actually, This is true for any epidural actually, because if we want to place an epidural for a long-term analgesia, actually they put a dye and see it under the image intensifier to see where the dye has spread. So if you caudal, if you want to be sure, you have to do it in that way that you are able to see the spread of the dye, spread of the local anesthetic. So that is the problem, that this is one thing, and another thing is that you need to give a lot of volume. So there are less indications for caudal in adults actually. If you want to do some those procedures in which you are giving caudal, you can do it in spinal, either in the form of saddle or in the form of this one proper spinal or saddle block. So this is the reason that we are not doing it in adults. But there is no there's no point that you cannot do it, or it's like contraindicated. It's not like that. Usually the ligaments will be fibrosed, so you will not be able to enter it. Okay, because you are trusting the landmarks, and if your needle is not going passing through it, that's the reason for not doing it. Okay, actually I have done in adults as well caudal block.
And so what is the minimum age? In our setup, we don't do less than 1 year of age.
No, it's not like that. Even even spinals they are doing it in even neonates. There is no contraindication. You can do it. The reason, there will be some other reasons. There is no problem that you cannot do it in less than 1 year. You can do it.
Thank you, sir. Thank you.
Okay, so you can do it in less than. Okay, so just a second, I was just finishing this one. So these are the some of the points. Yes, another question: if you give caudal, so how can you pick the toxicity? What will be the signs of toxicity? Anyone?
Tinnitus?
No, in pediatric, we are talking about pediatrics.
Bradycardia,
Bradycardia, okay, no,
hypotension.
no. You know, Dr. Humera, that you don't think before answering the question. And I'm always hard at you because I'm expecting a better answer from you. This is in adult. We are talking about pediatric. Is there any difference? Because the baroreceptor reflexes are not like in adults. So what will be the response of toxicity in pediatrics? How will you pick it?
Could be hypoxia.
Yes, hypoxia is the usual sign of toxicity in pediatrics. Okay. Okay, so we will just have a look, because there are a number of options for giving. So one of them is this pudendal nerve block. Okay, and other one that we are doing it in the base of penis. I just open a document for it as well. Just a second. Yes. So penile block is being given at shaft of penis, and just actually it is to be given deep to buccal fascia. Okay, so and like any other block, there can be bleeding. So this is how you see here they will be giving it.
So it's a bilateral.
Bilateral. You have to give bilateral. Okay. So you have to give bilateral, and according to the same thing, that if you are, you will just be calculating the safe dose like I have told you ever. Okay. So do you know about this 1:30 o'clock or 3 o'clock? Do you know about this thing? that how much is this hour if you are making it here?
3 o'clock and 11 o'clock, is it?
Yes, this is 3
one-
o'clock. This is 3 o'clock. This is 11 o'clock. Okay. So actually you just imagine a clock. So this is 12. Okay. So roughly like here, it will not be actually 3 o'clock. It is 1:30.
Sir, 1 and 11.
Yes, 1 and
check
11,
it.
not 3. Not
Yes,
3. See?
this is 1, this is 11,
This is
and
3.
center is 12.
Yes, this is 3, this is 4, 5, and then 6, 7, 8, and then 9, and then 10, 11, and 12. Okay. So this is how we can just calculate this hour, this clock. Okay. So actually they say that some of the nerve, there is another nerve which is coming, ileo, some of the portion, if they are opening some of the, if I'm not wrong, the ilioinguinal nerve, some branch also come. Okay. So terminal branches of ilioinguinal gender from the blocked by infiltrating.
So
a
it's the
subcutaneous-
L1 nerve.
Yes. So where it meets the scrotum, the shaft where it meets the scrotum. So they just block that one as well. Okay. Never use a vasoconstrictor.
Would a tab block be helpful?
Tab block, no. Because actually the tab block will be, tab block will be covering the up one part,
L1.
but not the sacral
L1.
part. Yes, yes,
L1.
you are right. In that way, yes. But actually we will not give it because the main nerves here are sacral. Some of the portion is coming from the higher up, but usually it is the portion where they are doing the surgery, that is main part is from the sacral nerves. Okay. So that's the reason.
Sir, some books mention only dorsal nerve of penis, which is branch of pudendal nerve.
Yes.
But here it is mentioned genitofemoral and ilioinguinal.
Some of the area of the skin.
The,
It's not the main nerve. This is not the main nerve. That's what I'm telling you. That that's not the main nerve. Okay. The main nerve is the same pudendal nerve. Where like
okay, sir. If
which is mentioned
these
here.
nerves are involved, then saddle block will not be effective because their supply is from L1.
You are absolutely right. You are absolutely right. And that's what I'm telling you, that this is not the main nerves. Okay. This is not the main nerves. If you are talking about the main analgesia, you know, we are giving adductor canal block for knee analgesia. Okay. But knee nerves, knee is receiving nerves from many other nerves. But you just try to block which is the more important, which can give you adequate analgesia. We don't need to block everything. Okay. That's difference between analgesia and anesthesia. In anesthesia, you need to knock down everything. Otherwise, you cannot do the surgery. Okay. For analgesia purpose, you can block part of it. Okay. So you're theoretically, you are absolutely right. That if you want to get it up to that level, then you cannot give. Okay. So actually there is another midway between that. You give the dose and then you let the patient sit for a few minutes, and then not for as much time we give for saddle. So in between it will go, it will have some effect on the lower, and it may spread slightly to the higher as well. So you can get by that way as well. Okay. So this is okay. So another point I wanted to discuss, that when you are giving caudal, should you use the needle or cannula? Because actually I was trained by needle. Okay. But actually that's not the safe way.
Yeah, 22 gauge Branella.
Yes. You should use the cannula rather than needle, because it can theoretically, it can enter in the, I just actually, so many things I just want sometime. It is, I just want to show you this whoosh test and swoosh test. There are two tests here. I don't know where I saw them. Yeah, this you will feel the sacral cornu, and then you will enter in the this slightly angle, and then you will make it straight and you will reach it. And there are two tests actually. If someone knows about it, there is one with the air and one with the saline. Yes, here you see swoosh test, and there is one whoosh test. I don't know which one, I forget. One is for water and one is for air. Okay. So should you better, it is better not to inject air. Even new people, I will suggest juniors to get yourself tuned for even for epidural with saline rather than air. Okay, because air can cause a patchy block. Air is associated with the this one as well, air embolism, especially if we are using it in a pediatric patient, because even the small one will be big. Okay.
Sir, some books contraindicate using air, and they are very much against using air.
Yes, that's what.
Only normal saline.
Yes, normal saline. And actually, when you are using normal saline, you are doing it with constant pressure rather than intermittent pressure, which we use for epidural. Okay.
Okay.
Usually, because all of us are trained in a similar fashion. So, but here, when I see their residents here in Saudi Arabia, they are all using saline, not air. Okay. So
Sir,
saline
could you
is.
explain the procedure how you do it saline? You take a drop of saline and
No.
then what?
No. That is hanging drop method. You are talking about hanging drop method. I'm not talking
Then
about
what
this thing.
method are you talking about?
I'm talking about the loss of resistance syringe. You don't take air. You will take saline. Okay.
Gee, and then what will happen?
What will happen that when the air, when you will reach the space, the saline will be injected inside, just like air. Usually what we do, that we are going intermittently. Okay. We are going millimeter by millimeter, millimeter by millimeter. But actually here, people who are trained in that way, they are using the constant pressure way. They are they are like after 3-4 cc, as we do 3 centimeter. When they reach there, after that they don't stop. They have a constant pressure. They are pushing. Their pressure is on the syringe, and they are pushing inside. Okay.
And
Actually,
once the epidural space is reached, the saline is sucked in.
yes, saline is sucked in. I have done it few times, but actually because I have almost deleted, I have reduced epidural from my practice because of some other reason, because in our hospital there is no post-op follow-up for epidural, so we are not giving epidurals here. I'm replacing it with other blocks like erectors. Actually maybe after a few years there will be no epidural. You will be surprised to listen my comment, because erector spiny block is a wonderful block to give analgesia in many of the places where we are giving epidural, and even we can place catheter through erector spiny block. Okay. So anyways, these are the basic concept about how to give this one anesthesia and analgesia for this this procedure. The summary will be that you should be knowing what age group the baby is. You will be safely calculating the safe dose. Like you should be knowing about how to calculate the safe dose, and then you can see what are different options you can use. In younger age group, if they are doing it, they can do it in local, but actually it's baby will be crying. Okay. Recently I had myself my baby circumcision at the age of around 1.5 months, and I did not give any anesthesia. I just did it they did it in local, because it was not the traditional, because now they are doing it with bell. They just put, they don't do any suture or anything, just put a plastic bell, and it remains there for 1 week, and exactly after 1 week it is because the process is that they just close it and cause ischemia, and it remained there for 1 week, and after that it is removed. So actually I myself has experienced just recently. Okay. So so there are different things. That's why always, whenever you are for practical purposes as well, and actually for at least for written and this one Viva point of view, MCQs, yes, MCQs will be a little tricky. But in MCQ, if you have all the aspects clear to you, I can guarantee you will not miss the MCQ. Because in MCQ, what's the problem? If you don't have your horizon is open, that you know the other things, other options, because usually how people are practicing the MCQs, they are just trying to find the queen. What is the queen? What is the answer? They are not concentrating as much as they should for the other options. And rather, if you ask me, you should try to change the statement. You should try to change the statement in the stem. You should try to change the statement in the stem, that other options become the answer. This will not be true for everyone in every MCQ, but in majority of MCQs, you can do this, that you try to change the stem in a way that now the other option, which is not true, becomes the option. So if you practice in that way, you will be able to have a better concept. Okay, because sometimes you are only concentrating on, you are missing something. If you miss something in the stem, you will not be able to pick the answer. Okay, because MCQs, that's why is a real test of knowledge, in the sense if you are using it correctly. But because there is always a matter of guessing, you can have without concept, you can cram the answers. And especially in our part of world, because I have strong opposition in Pakistan, in a country like Pakistan, to have a total MCQs pattern, where unfortunately we don't have the mechanism to develop a quality pool. And that's the reason that MCQs, they are good, they are not bad, but they are very limited. So that's why you people are very easily, you are able to develop a terrible half-cut zombies. I will say that these MCQ pools are zombies, and you are relying on zombies. You are having either the options are wrong, either the stem is wrong, and you are having a rape of your concept. I'm sorry to be very frank, but that's a rape of your concepts. You are doing a disaster to your concepts by only following this half-cut zombie pool. Okay, so please, whenever you are preparing for MC, I will just take 1 minute to tell you that if you are reading, because this book I will highly suggest you people for regional anesthesia. It's a wonderful book. Okay, so whenever you are reading about it, you sometimes you are only finding you are reading the stem. Okay, after for revision, I will never suggest you to read the stem. Try to read only the explanation, because you will find the real revision only by, because if you are reading MCQs a number of times stem, you will memorize the stem even. Okay, so actually I wanted to just tell you that whenever you are reading an MCQ, you just try to read each and every word of the stem at least. Like here, it will not be true for everything, but which of the following is a true statement in patient with myasthenia gravis? Okay, so if I want to practice this, so when I reach this word myasthenia gravis, I will revise in my mind, what is myasthenia gravis? Okay, it is a disease affecting the post-synaptic acetylcholine receptors. So there is a problem in the neuromuscular transmission. Okay, so it is not pre-synaptic, it is post-synaptic. So there is problem with the acetylcholine receptors. Okay, this is a revision for you. Okay, now thymectomy can be done under general anesthesia or high thoracic epidural. So you should be knowing what is thymectomy. This is how you should be studying. If you are studying in that way, maybe you are able to have less number of MCQs, but the quality which you will be getting will be very good. Okay. So for thymectomy, you should be, whenever you are thinking about any surgery, you should be knowing where is the incision. So for thymectomy, because I have never done thymectomy, so unfortunately I am short of ideas about thymectomy. I don't know where they give the incision, but it can be done with by this VATS. They are doing it by VATS as well, if I'm not wrong. Okay, So they are doing it with video assisted thoracoscopic surgery. So their approach will be dependent. So according to the approach, you will be deciding. Okay, all local anesthetics are safe. Supraclavicular brachial plexus block are safe for upper limb surgeries. Benzodiazepine and opioids are safe to use for sedation during peripheral nerve block. So what will be the most true statement? This will definitely be wrong, because it's not safe, because myasthenia gravis patient can have respiratory insufficiency. So the word safe is very hard. If you are claiming that it is safe procedure, it means there is no problem related to it. So this one is definitely wrong. Supraclavicular brachial plexus blocks are safe for upper limb surgeries. Same answer. No. Why? Because supraclavicular block can block which nerve? Which can?
Phrenic nerve.
Phrenic nerve. So if phrenic nerve is blocked, then the respiratory insufficiency will be. All local anesthetics are safe. All local anesthetics are safe. I don't know. What does?
No.
Huh?
No, sir. Cocaine is a local anesthetic. It's not safe.
No. They are. You see, that's the problem. You should be thinking about the statement. So whenever you are trying to read the MCQ, you should be reading with the stem. So we are talking about myasthenia gravis. Okay. So I think if I'm not wrong, this should be the answer. Let's see. 42. Okay. So that's the correct answer. So like, for example, you see that's because this is a wonderful book. It's one of my, I used to say, darling book. This book is also one of my darling book. This is amazing book. It's very
What is the name of the book?
What is the name of the book? This name of the book I will tell when you will transfer $1,000 in my account. Okay.
Astaghfirullah. Astaghfirullah, sir. I thought you asked only for moral commitment. No
Yes.
money involved.
No, I am just kidding. This is clinical anesthesia viva book. Okay. This is clinical anesthesia viva book. And
Okay, sir.
this is regional MCQs, regional anesthesia book. Okay. So that's how you should be learning. So do you see, that's what they have. Myasthenia gravis is an autoimmune disease characterized by weakness and progressive fatigability. There is antibodies against the alpha subunit of postsynaptic acetylcholine nicotinic receptor. Medical treatment includes anticholinesterase, steroids, immunosuppressants, and surgical treatment includes thymectomy. Okay, it can be done under general anesthesia or thoracic epidural anesthesia. Full coagulation profile.
Sir, which drug is longer acting, tetracaine or bupicaine?
Tetracaine. Okay. Full coagulation profile must be obtained prior to regional anesthesia, as platelet function might be affected by the steroids and immunosuppressant. So that just for brainstorming, whenever a word, any disease come in that stem, you should be scanning yourself like this. What is the disease? What is the pathology? What is the possible treatments the patient may be taking? So because whatever the option you will be choosing will be according to the disease. So myasthenia gravis patient can have immunosuppressants. So immunosuppressants can affect bone marrow. Immunosuppressant can go renal function dysfunction, can cause renal problems. Immunosuppressant can cause a number of problems, liver dysfunction, things like that. Okay. So similarly, steroids. So all the steroids related concern should be in your mind. Anticholinesterase. So anticholinesterase related problems. Okay. So if you are reading MCQs like this, my dear friends, I can guarantee you that after some time you will realize that how much knowledge you are gaining. Okay. So I don't discuss MCQs much with you people, because I suppose that if you understand what is the chunk of the knowledge, it will be easier. But because you people are reading Morgan like a novel, so Morgan is just like an invincible thing. You will never be able to swallow understand, correlate that holy book, which is a curse on anesthetics. I will be very open to say that, and Morgan should be discouraged at your workplace. Not because I am having any personal grudge with this person who has written this book, but the problem is that even he has not asked you to read that book in that way. That is Notes of Miller. That's a short form of Miller. Has you seen written anywhere textbook of Morgan? No, it's notes. So how can you rely on notes? It's a notes. It's nothing, believe me. And there are so many people with whom I have arguments, and people start fighting with me. You are breaking our religious concept. What are you saying? I say, please read MCQs books. Please read review books. Please read articles. There is no replacement for articles. I again and again request all of you. If you people, if the juniors are listening to my message, if you are reading articles from day one of your training, after some time, I can bet on you that there will be no comparison of the knowledge. Okay, so I took a lot of time. Thank you very much for your presence. For actually just one thing, that whenever you are reading any blog, I will suggest you to read from or see videos from Naisura. Okay, so this should be your textbook for regional anesthesia. Naisura, you will find so many things. Okay, so there is no need, but you know what you say in our language, chas nahi pura hunda. You are not completing your chas till the time you are not reading book. So it's just an addiction, and it's a very bad addiction. Okay, and just like we say, Asman se gira
Sir,
Asman se, I'm sorry if some non Pakistani people is there. When we say that if we are inviting, we are thinking that we are escaping from any trouble, but we are stuck in a bigger problem. So that's what we do. The people who are jumping from Morgan, they are dropping themselves in even a terrible book which is problem oriented. Okay, so they are very happy.
Out of the frying pan into the fire.
Yes, definitely the artistic word from you. Okay, so actually problem oriented, you cannot revise, you can never reproduce, you can never ever understand that book. So what is the advantage of reading so many? If you cannot read, you cannot, remember one thing, your saving is your life. Okay, so the saving is that what you are able, like whatever, I don't know how much I know, but whatever I am able to speak out, that is my saving. So read in a way that you are able to reproduce it in front of anyone. If you read something and if someone is asking you any question next day, then you are smiling and making faces that you are unable to reproduce it. What's fun of reading it? Just tell me. And that's hurt me a lot, that our people, I can guarantee you, my dear friends, that when they are being asked, sir, what should we read? They finish their guidance. Please read Morgan and Mikhail. I still remember face of one of the professor when he told some of the people who came in front of him, please read Morgan and Mikhail. I was really shocked, because this the guidance is very easy. And after that, he will run away and the person will be suffering. Okay. I can bet about it that people say, this one, sir, first reading will not tell you anything. You have to repeat again and again. And after third, fourth reading, you will be able to reproduce. Okay. So what the hell you are doing? You are doing post-graduation and you are making someone in a tunnel vision. Rather, not even tunnel, even worse than tunnel. You are sending that resident in Guantanamo Bay jail if you are telling that to read Morgan. Really, I'm sorry. I have very bad feelings about Morgan, because I suffered. I really suffered. My whole family suffered, and I regret. That's why I'm doing jihad with you people. I am wasting my personal time. Believe me, I just came from the hospital. I had a nap, and then after that, I talked to my father, and now my family is waiting, because once I will finish the class, I will go out with them. So that I'm telling you that I'm doing this thing just because I suffered a lot. And I'm just literally begging you people to get rid of that stupid source which is hurting you. Yes, Dr. Humera?
Sir, I would like to ask the question about awake fiber optic. What position of the patient is ideal for awake fiber optic?
Awake
Because
fiber optic,
today I had
just like a little semi-sitting position. It will be easier.
if the patient is tetanus, then
Tetanus patient, you will do awake fiber optic?
she had locked jaw and they were trying to intubate.
No, Dr. Humera, I'm sorry. Again, your question is not a very good question. You will do tracheostomy. Okay? You will not do awake fiber optic. How will you do awake fiber optic in a patient with tetanus? Okay, thank you very much. Bye-bye. Assalamu alaikum.